1 year after starting her diabetes, she was diagnosed with depression. Her risky behavior, suicidal thoughts, and bad compliance was also connected with this. And this is not just a silly coincidence. Neuropsychiatric disorders are very common in patients with mitochondrial disorders and in mitochondrial inherited diabetes and deafness as well. Sometimes patients present with aggressive or unstable behavior, sometimes present with school difficulties, mental retardation, impaired memory, and some of them may be treated due to psychotic symptoms anyway. What was not presented in our case, but what we can also find in MIDD patients, are structural or functional impairment of the brain and central nervous system. During her disease, during her diabetes, she also presented with some gastrointestinal symptoms. At first, 1 year after admission to our center, ultrasound revealed bile stones, and sometime later she presented with gastritis, what was confirmed by gastroscopy. In mitochondrial diseases, gastrointestinal disorders are quite common. Most patients suffer from very slight symptoms like constipation, diarrhea, but there are also some description in the literature of even pseudo-obstruction. Some authors suggest that we may help patients with introducing coenzyme Q10, and it may be helpful, but it's still under consideration. The gastrointestinal symptoms are thought to be one of the main causes of the very low body weight of the patients with mitochondrial diabetes. But in our case, our patient presented with the systematic increase of body weight. It was very hard to keep the strict diet. She was not compliant. But the reduction of body weight was achieved by changing the insulin therapy and starting the treatment with determin and aspart, which was done by Professor Wojcik and his team, and this is already described. According to the oxological data, most of the patients with MIDD are short. The final height for male patient is usually below 100 and for female 150. Our patient was also slow. According to the Polish data, to the Polish normal values, her final height was below 3rd centile. During the second year of diabetes duration, she presented with arterial hypertension. Almost 1/3 of the patients with mitochondrial diabetes, according to the data from literature, may suffer from arterial hypertension. But what is very interesting in this group of patients, we have a quite wide spectrum of cardiovascular disorders, left ventricular hypertrophy, cardiomyopathy, and sometimes life-threatening arrhythmias. We have another patient with mitochondrial disorder with Kern-Sauer syndrome, and she's suffering from diabetes, and in spite of her very young age, she's a teenager now, she has a very serious cardiomyopathy now. Finally, just after discharging from our center, she was diagnosed with early stage of hypoacusis. This is a great example of the progression of deafness in this disorder, because at first when we thought about mitochondrial diabetes, we performed the audiogram, and it was completely normal at the beginning of the disease. Deafness or hypoacusis is present in almost all patients with mitochondrial diabetes and deafness. It's age-related, but may be the first manifestation of the disease in 42% of the patients. Why this is the progressive disease. This is also connected to the defect of the mitochondria, because the lack of ATP cause the inappropriate concentration of the potassium level in the endolymph. That affects the Corti organ and makes it impossible to amplify the sound waves, particularly at high frequencies. The degree of the hyperacusis is different in different patients. Some of them may have 100% verbal discrimination preserved, and some of them need the cochlear implants in relative early age. At the same time, the fundoscopy revealed the first signs of macular pattern dystrophy. It is very hard to find macular pattern dystrophy, especially at the early stage in fundoscopy. You need well-trained ophthalmologists. In some cases, additional examinations are needed. And here we can see from the literature, not from our patient, some angiography of the fundus of the eye. What was not diagnosed in our patient, or maybe what has not been diagnosed today in our patient, we don't know what is going to happen, is the kidney disease. The prevalence is quite high according to the pretty good control, metabolic control, and low HbA1c in most of those patients. We have almost 1/3 patients with progressive kidney disease. Some of them need kidney transplant. The biopsy showed that this is not the effect of diabetes. This is not the diabetic nephropathy. This is rather the primary mitochondrial defect anyway. Sometimes the symptoms of muscular weakness, they are present in almost half of the patients, usually after physical exercises, after prolonged walking. Some patients may present with lipid disorders. It was not diagnosed in our patient, but as I know from the history, her mother suffered from severe dyslipidemia. And there are also some descriptions of hypoparathyroidism in the literature. Let's go to the summary. Mitochondrial diabetes and deafness inherited from mother is quite rare disease. But if we have a patient with diabetes mellitus, we not always have the full symptoms at the beginning. The hearing loss, the macular pattern dystrophy may be not present at the beginning of the disease as it was in our patient. But anyway, if we have patient with the maternal history of diabetes, with coincidence of neuropsychiatric disorders, muscular weakness, gastrointestinal disorders, or short stature, we should thought about this type of diabetes. Thank you.
Thank you very much for this interesting and very complex case. So now, again, the questions, comments are welcome.
I want only to add that we always should remember about Wolfram syndrome, because some part of presented here, I mean diabetes mellitus, deafness, changes in central nervous system. Both entities share those features, and at the same time, in Wolfram syndrome, each component may appear not simultaneously, but step by step. So, especially in pediatric age range, we should also remember to distinguish between those two units.
Yeah. Thank you for these comments. It's very important.
Professor Wojcik.
I think this was a very valid point. One of the features that could be helpful to distinguish between those two would be the pattern of inheritance, obviously maternal versus autosomal dominant. However, when you are dealing with such small families, you can really not judge what kind of the mode of inheritance are you dealing with. And one more question. We have a specific clinical problem here. We have an MIDD patient with obesity, okay? Sulfonylurea not effective, metformin essentially contraindicated, although not solid base for that, but we are trying to avoid that. On insulin, we are dealing with weight gain. So do we have any suggestion of the solution? How about GLP-1 agonists?
Maybe we may think about it. In this patient, the solution was pretty well because the treatment with insulin analogs was helpful and she decreased her body weight. Maybe it was a few years ago, so maybe now we have more possibilities. And
yeah, I'm asking you the question that simply I should be asking.
I can't answer that just strict.
She's currently under our care, but I think that this is a way to go.
Probably.
Other questions, comments? Please, thank you very much again.